Hello, my name is Tarika McCall, and I am an assistant professor at Yale School of Public Health. Today, I will present the results of a study conducted with my colleagues, Stephanie Date, Dorothy Alexis, Stephanie Whiteman, Salil Dick, Louis Marcon, Meredith Campbell-Britton, Bela Tessier-Sherman, Cynthia Brandt, and Karen Wong on usability testing of the Eastern Caribbean Health Outcomes Research Network data sharing platform. I will begin by briefly discussing the background of the study and creation of the data platform. Then I will present the methods, results, and future directions for the study. So the Yale Transdisciplinary Collaborative Center for Health Disparities Research focused on precision medicine, also known as Yale TCC, is a collaboration between the Equity Research and Innovation Center and academic, public health, policy, and community stakeholders in Puerto Rico, the U.S. Virgin Islands, Trinidad and Tobago, and Barbados. This collaboration expands the existing foundation and knowledge base of the Eastern Caribbean Health Outcomes Research Network, also known as ECHORN, which is a unique regional research network aimed at reducing the burden of non-communicable diseases in the Caribbean via strengthened regional research capacity. The ECHORN research portfolio is anchored by the ECHORN Cohort study. Launched in 2013, the ECHORN Cohort study is a prospective population-based longitudinal study following 3,000 community-dwelling adults aged 40 years and older who are permanent or semi-permanent residents of the U.S. Virgin Islands, Puerto Rico, Barbados, or Trinidad and Tobago. In the Caribbean, primary care is mainly delivered in public polyclinics by a variety of providers, with most countries having no need for patients to register with primary care doctors. The Caribbean's unique identity is geographically and culturally diverse, with residents that speak multiple languages, follow various religions and diets, live in extremely varied community settings, from urban populace to rural village, and different socioeconomic statuses. They're also governed by or through different civil societies. This diversity is rarely captured in systematic data collection, as the Caribbean has limited representation in large-scale surveillance programs. This study is aimed at evaluating risk and protective factors for the development of cancer, diabetes, and cardiovascular disease in this population. So the first wave of the ECHORN Cohort study collected data from each participant via survey tools, clinical assessment, and biological samples. Data on socio-demographics, health behaviors, healthcare utilization, medical history, and other domains were captured from participants enrolled between 2014 to 2018 via a confidential self-reported questionnaire, which utilized audio computer assisted self-interviewing to increase validity. There's a paucity of health research that exists among marginalized populations, including those in the Caribbean, with underrepresented individuals being affected by structural and data inequities that limit the usefulness, availability, and accessibility to health information systems and research-generated data. Even when collected and available, the information systems may not be structured to allow for individual-level data to be assembled and relationships investigated. This study aims to evaluate the risk and protective factors for the development of cancer, diabetes, and cardiovascular disease in this population. So the ECHORN study objectives are to address the need for regional research infrastructure and collaboration on non-communicable diseases, recruit and follow a community-dwelling adult cohort to identify unique risks and protective factors for cancer, diabetes, and cardiovascular disease, and to increase regional capacity to design, execute, and translate research into policy and practice. So today I present on the results from the usability testing of the ECHON Cohort Study data sharing platform. It is a publicly available searchable database of aggregated study data aimed at advancing the dissemination of health data throughout the Caribbean. The data sharing platform was developed by a multidisciplinary team, which included clinical providers, clinical informaticians, and health equity researchers. Feedback from stakeholder engaged discussions informed further development of the functions and content for the platform. Users can conduct descriptive and bivariate analyses and create graphs and tables. They can also convert the graphs and tables to different file formats, download the results, or save the query to retrieve it in the future or share with others. So the purpose of the study was to evaluate the user interface on how well it supported users in the completion of basic tasks. The findings will be used to ensure that the data sharing platform is accessible and beneficial to those within and beyond the scientific community. The field of health informatics has a research replication problem, and this data sharing platform will help to facilitate a culture of research replicability and validation by providing access to de-identified health data for 3,000 adults in the Caribbean. Data sharing, coupled with community-based participatory research, has the potential to increase the usefulness of data for underrepresented populations. So for our methods, we recruited community members aged 18 years or older residing in the Eastern Caribbean to test the usability of the data sharing platform. Recruitment methods included receiving an invitation to participate in usability testing of the platform via an email sent to listservs, posts on social media, or word of mouth. Purposive sampling was used to increase diversity in the sample, so for example, for age, and generalizability of the findings. Each participant received a $20 gift card for completion of the study. So in March and April of 2021, we conducted one-on-one usability testing sessions with 17 participants. The sessions were moderated by Yale TCC fellows trained to conduct usability testing. Each session was completed remotely using the Zoom video conferencing platform. The moderator used a script to conduct the sessions, and participants were informed of the purpose of the usability testing and that the sessions would be video recorded and last approximately 30 minutes. After assigning remote control to the participant, the moderator instructed them to perform a series of 4 tasks in the platform, and importantly, to speak aloud their thoughts and actions as they completed these tasks. The cognitive walkthrough method was used to evaluate the user interface design on how well it supported users in learning to complete tasks. Specifically, this method was used to evaluate the ease with which users can perform a task with little or no formal instruction or informal coaching. After usability testing, each participant completed a brief self-administered web-based survey. The survey included an adapted version of the System Usability Scale, also known as the SUS, and socio-demographic questions. The participants were given 4 tasks. For example, they were asked, please show me how you would find out the number of individuals in each location of the ECHON cohort study. Display the results as a pie chart. Another example is show me how you would find out how many individuals ever had cancer by age group and display this as a bar graph. After completing the task, participants were asked the following open-ended questions about their experience using the platform. For example, they were asked, what do you think about the way the website looks? What do you think about how it functions? What are some things that you would like to see change? And so on. Moderators completed field notes for each session to document issues like sticking points, confusion, missing items, and unmet user needs. In addition, I have independently viewed the video recordings for each session, noted observations, and debriefed with the moderators one-on-one. So for the results of the study, 16 of the 17 participants recruited completed all the study activities. These participants ranged in age from 19 to 65 years, with mean age of 34.6. Most identified as female, and the sample included participants from 8 Caribbean islands. The 4 sites for the ECHO and Cohort study were also included within the sample. Most participants were college graduates, and the majority had at least one computer in their home, and 63% had 3 or more computers in their home. All participants also had internet access in their home. Among the 16 participants evaluating the usability of the data sharing platform, the overall average SUS score was 73.1, and this is on a scale of 100. This translated to a good usability rating. Individual SUS scores were categorized as best, imaginable, excellent, okay, or poor. There were no scores that were in the range of awful or worst imaginable. Most participants rated the platform above average. Older participants were more likely to rate the platform's usability lower than their younger counterparts. And there was no observed difference in rating the platform among participants that are college graduates and those who were not. Participants completed cognitive walkthrough Think Aloud sessions, and the first task required that they show the moderator how they would find out the number of individuals in each location of the ECHO Cohort study and display the results as a pie chart. All participants were able to complete this task with little to no assistance. However, most participants had difficulty with the remaining 3 tasks, all of which required some use of more than one variable and required a little assistance to complete these tasks. Participants stated that options for selecting more than one variable was not intuitive. The participants' qualitative feedback on testing the data sharing platform, as presented in this table, showed that participants overall felt that the colors and graphics were nice, the system speed was fast, the graphs were easy to read, and their interface was clean. General recommendations for improvement included adding a frequently asked questions page and help button, as well as a tutorial on how to use the site. Participants also suggested adding a title and information about the purpose of the study on the main page and making the site mobile friendly. Regarding the content and features, participants liked being able to find information on chronic diseases. They gave positive feedback about having options to save the graphs as images and export tables to Excel, as well as the ability to save graphs to the site. Participants recommended allowing users to save the graphs and tables by right-clicking on them or using the ellipses button, adding a button to the chart tab to save graphs, and they also recommended adding hierarchical filtering capability. Regarding navigation and error prevention, participants thought the drop-down menu made things easy to find and grouping variables by category was helpful. Recommendations for improvement included relabeling the buttons or selecting the number of variables to make the functions clear and easier to apply. Participants also requested making the buttons bigger, moving the buttons to the top of the chart table area, and adding labels above the buttons so that users do not have to hover over the button to find out its function. The main strengths of the usability study were its use of the cognitive walkthrough think aloud method and administration of the system usability scale to obtain both qualitative and quantitative feedback on the platform. In addition, 16 participants completed the study, providing a more than adequate sample size. Also, participants from all 4 study sites were included. However, there were some limitations for the study. Most of the participants identified as female and all completed at least some college studies. This may limit the generalizability of the findings, especially to those who have not completed any college studies. Also, usability testing sessions were conducted remotely via video conferencing, and this was due to physical distancing restrictions caused by the COVID-19 pandemic. However, despite these limitations, the study yielded useful information to improve the usability of the platform. So to our knowledge, this data sharing platform is one of the first to provide de-identified and aggregate population level data from the Eastern Caribbean region to participants and community members. We are well aware that poor usability negatively affects user satisfaction and engagement. Therefore, our future work will include incorporating feedback from the usability testing to further develop the platform prior to its launch. The available variables will be expanded and new features will be added to increase the usefulness of the platform, and we will also add data from the second wave of data collection in the future. Participatory data sharing platforms, such as the one we developed and evaluated in this study, have the potential to reduce health information inequities in the Caribbean. Improving the usability of the platform will help to increase its use and the likelihood of greater dissemination of the ECHORN cohort study data and other related projects. With this regional sustainability, the platform can be used to inform real-world health questions and become an accessible online space for providing health information and new health insights for all Caribbean people. The results of the study will be used to continue to refine our approaches to data integration and sharing and inform ongoing global discussions on an informatics framework to support global partnerships for digital innovation and achievement of health equity. Here are our selected references. And we would like to thank our leaders, Doctors Nunez-Smith, Nunez, Maharaj, Raxter, Doctors Adams, Nazario Delgado, Martinez, and Hassel for their dedication to improving health outcomes in the Caribbean. Special thanks to our usability testing and ECHORN cohort study participants and the ECHORN cohort study site teams for their participation and efforts in supporting this important work. We would also like to acknowledge our funders, the National Institute for Minority Health and Health Disparities, and the National Heart, Lung, and Blood Institute. Also, I would like to acknowledge the support I received from the National Library of Medicine's Institutional Training Grant for research training in biomedical informatics and data science at the Yale Center for Medical Informatics. Our website is echorn.org. You can also scan the QR code shown. Please feel free to contact us at ecc@yale.edu if you have any questions about the study or data platform. Also, follow us on Twitter at ECHORN Project for study updates. Thank you.